Good afternoon, ladies and gentlemen. I'll be giving a case series on posterior polar cataract, a surgical black hole. A short introduction. Generally, posterior polar is present at birth. Now, there may be two types, dominantly inherited and sporadic. Dominantly generally have a variable expressivity. However, you'll find a lot of times they are bilateral, and sporadic may manifest at a later age, but the ones which are unilateral are generally sporadic. There's a positive family history in around 40-45% patients, and it is bilateral in almost 65 to 80% studies. Various studies have reported this, and there is a mutation on the PITX3 chromosome 10. Now, this is generally on the posterior pole of the lens associated with remnants of the tunica vasculosa. What is important here when you treat these patients or manage these patients, you need to know that this is generally tightly adherent to the posterior capsule, and it is often associated with a pre-existing dehiscence. And studies have reported various rates of dehiscence ranging from as low as 7.1% to almost as high as 36%. There are various studies available. There's a classification also giving. What you need to remember is type 3 and type 4 are the ones which are most prone to pre-existing dehiscence. That is where you expect complications. Type 3 are the 3 and 4 are the ones where you need to be careful when you operate them. Now, this was a analytical study of posterior polar cataract. This was in a zonal center of the armed forces where I was posted. 46 eyes of 38 patients with posterior polar cataract underwent phacoemulsification with a PCL implantation. All were operated by a single surgeon and on a Bausch & Lomb Stellaris phaco machine. And the surgical factors of interest in our study were the rate of PCR, the nucleus drop, and post-operatively the best corrected visual acuity. Another important thing what people need to remember is you have to counsel these patients, because patients with a type 3 or type 4 and a larger polar, which is especially dominant, they might have amblyopia pre-existing because it has been present since birth, and a lot of times this amblyopia is not reported because it is in the range of 612 to 618. Binocular vision is very good, so you have to counsel these patients. They might not have a full correction of visual acuity 612 or 69 post-operatively. We excluded all cases with higher than grade 3 nucleus, and the parameters during surgery were generally low flow. We reduced the bottle height, we reduced the vacuum, and power varied from 20 to 30 because the highest grade of nucleus that we had was grade 2. So a lot of times, and the grade 1 nucleus could be removed during just the epi mode itself. Now, the general principles that we followed were we kept a smaller CCC of around 5 mm. Denser cataracts, grade 2 plus, we kept a larger CCC. No dissection was done. This is standard for polar cataracts. Tried to get a golden ring in all cases because that is a marker of a good delineation. That is where your nucleus removal becomes easy. If you don't have a golden ring, and then you go ahead with the phacoemulsification, there are chances you will destabilize the entire epinucleus and you will end up with a dehiscence, especially if it is tightly adherent. What you need to remember is do not rotate the nucleus. Generally, a grade 2 nucleus you can manage without rotating also, and you can phacoemulsify it in the bag. A soft cataract during hydrodelineation, try and prolapse it. One edge of the nucleus prolapses, removal becomes very easy. You don't need to emulsify in the AC, but partial prolapse makes your life easier. Grade 2 nuclei were present. Slow controlled chopping in the bag without any rotation was done. Another important thing that you need to remember during the surgery is a picture similar to this. You can see this image here. This is what is a pseudo hole. Now, this looks like a rent, but this is actually not a rent. So don't be alarmed if you see this. This is a pseudo hole. This can give an appearance. This is the plaque which is removed during the phacoemulsification, and you have a remnant. So this is not a rent. This is a pseudo hole. Now, this I would say is a class type 2 polar. We go ahead with the surgery. You see there's hardly any nuclear sclerosis. It's a pure polar cataract, a small CCC. Do a gentle delineation and in the bag phacoemulsification, and then you remove the cortical matter wedge-wise. One step which I have not shown here is what is very important when you're removing the phaco probe after doing the phacoemulsification. In your left hand, take the visco cannula and through the side port, inject visco into the AC so that the chamber does not shallow at any time. This is what you need to remember. If there are no fluctuations in the AC, chances of a dehiscence go down. Another case, this is a larger cataract, polar. I think it's a type 3, I would say, delineation gun. Everything goes on fine here. If you see, the phacoemulsification is done in the bag, and we remove wedges of the epinucleus and then do the IA. Now, everything is fine till now. Now you can see it is adherent to the capsule. You can make out not a single piece of the polar has come out as yet. When we come to the last stage, suddenly you find there is a rent in the capsule. Now this is the last part which has come up. So do not disturb it, and you can easily implant a IOL in the bag. So you have to be aware that this situation might arise in any case of polar cataract. So we had a total of 46 eyes of 38 patients, 20 were male, 18 female, ages were 31 to 52. During this period, a total of 4,046 cataracts, so you can get an idea of the incidence of the cataract. All the patients were implanted with hydrophobic IOLs, 6 had a PCR, 13%, and no patient with a bilateral polar had a PCR in both eyes. What was surprising was all patients who had a PCR were greater than 40 years of age and had an associated NS or a larger posterior plaque. So this is the patients where you need to be careful. 41 patients had a visual acuity of 612 or better, and 84% had 6.9 or better. Now this is a comparison of the various studies. So our PCR rate, if you come to the second last column, is 13%, which is in the acceptable range. So conclude, it's a known surgical challenge. PCR rate was 13%. Basic tenets are pre-op counseling, low for parameters, do only delineation, no rotation, and you can generally have very good outcomes in these patients. Thank you.
Like, did any one of your patient had Daljit Singh sign, which you have mentioned? Like, any one of your patient had Daljit Singh sign?